Hello, my dear students, and welcome. Chalo, let's get started with today's topic, adrenergic transmission. Now, I know you know this is a very, very important chapter for your exams, so let's make sure we understand it inside out.
Okay, so here's our game plan for today. We're going to break this down into 5 logical parts. We'll start with the big picture, the body's action system. Then, we'll follow the journey of the main chemical messenger. After that, we'll talk about who receives that message, the receptors. Then, the fun part, how drugs can hack this system. And finally, we'll compare the 3 big players in this field. Simple, right? Let's go.
All right, first up, the body's action system. Before we get into the nitty-gritty details of drugs and receptors, we need to get a solid handle on the overall system we're dealing with. So we have all heard of the fight or flight response, right? Your heart starts pounding, your palms get sweaty, you're ready to either face the danger or run for your life. But have you ever stopped and wondered what is really going on? Not the big picture, but right down at the level of a single nerve ending. How does that signal actually work? That's what we're going to unpack. Okay, so to understand the system, we need to focus on the main character in our story today, and that character is the chemical messenger noradrenaline. We are literally going to follow its entire life story from the moment it's created to the moment its action is terminated. So this journey, you could call it the life cycle of noradrenaline, has 4 key stages. First, it gets released into action. Second, most of it is taken back up or reuptake. Third, whatever is left over gets broken down, which we call metabolism. And finally, the part that was taken back up gets put away into storage for later use. Release, reuptake, metabolism, and storage. Let's look at each one. So it all kicks off with an electrical signal, a nerve impulse. This impulse travels down the nerve, and when it reaches the end, bam! It causes these tiny bubbles filled with noradrenaline, these vesicles, to fuse with the nerve ending and just dump their entire contents out. And remember this, Butcho, this entire process is absolutely dependent on calcium. Without calcium coming into the cell, nothing happens. Calcium is the key that unlocks this release. Now, once noradrenaline is out there in the synapse doing its job, you can't just leave it there forever, right? You need an off switch. And the body has this incredibly efficient cleanup crew. Think of it like a powerful vacuum cleaner. It's a pump called NET, and its job is to suck back up to 90%, that's 90% of the released noradrenaline right back into the neuron. This is by far the most important way its action is terminated. Okay, let's get a little more specific here because there are actually 2 types of pumps involved in this reuptake. The first one, NET, sits on the main outer door of the neuron. It pulls noradrenaline from the outside synapse into the cell's cytoplasm. Then once it's inside, a second pump called VMAT2 takes over. Its job is to pack that noradrenaline from the cytoplasm safely away into the storage vesicles. And this distinction is clinically huge because different drugs block these different pumps. Cocaine blocks the front door pump, NET. Reserpine blocks the internal storage pump, VMAT2. You must know this difference. So you might be asking, what happens to the 10% of norepinephrine that the net pump doesn't catch? The leftovers? Well, that's where the demolition crew comes in. We have 2 key enzymes, MAO and COMT. Their job is to find any stray norepinephrine floating around and just break it down. They chew it up into inactive products like VMA, which the body then simply gets rid of in the urine. Think of reuptake as the fast off switch and metabolism as the slower final cleanup. All right, so far we've talked all about the messenger, how it's released and how it's cleaned up. But, a message is completely useless if there's no one on the other end to receive it. So, who is listening? That brings us to the fascinating story of the receptors. And for this, you have to remember one very important name, Alquist. Back in 1948, he was doing experiments and noticed something very peculiar. He saw that certain adrenergic drugs were very powerful in some tissues, but very weak in others. And another set of drugs had the completely opposite pattern. And from this simple, elegant observation, he proposed a revolutionary idea that is the foundation of everything we're learning today. And this slide is his big idea. This is pure gold for your exams, so pay close attention. He proposed that there must be 2 fundamentally different types of receptors, and he called them alpha and beta. And how did he tell them apart? By what he called the rank order of potency. For alpha receptors, the most potent drug is adrenaline, followed by noradrenaline, and isoprenaline is the weakest. But for beta receptors, the order is completely flipped. Isoprenaline is the most potent, followed by adrenaline and then noradrenaline. This rank order is the definition of alpha versus beta receptors. Don't you forget it. And here is the beautiful proof of his theory. On the left, we have a strip of aorta, a blood vessel, which is full of alpha receptors. And just as predicted, adrenaline is very potent. It causes a strong contraction. Now look to the right. This is bronchial muscle from the lungs, and it's full of beta receptors. Here, isoprenaline is the king. It causes a powerful relaxation. See? The effect of the drug depends entirely on which type of receptor is present in that tissue.
But this story doesn't end there. It turns out beta is not just one receptor, it's a whole family. We have beta 1, beta 2, and beta 3. And the location is key. Here's a simple trick to remember it. You have one heart, so it has beta 1 receptors. You have two lungs, so they have beta 2 receptors. Easy, no? And this is not just academic trivia, yaar. This distinction is absolutely vital for designing smart drugs that can target the lungs in an asthma patient without affecting their heart.
And of course, the alpha receptors also have their own family. Alpha 1 is the classic one. It sits on the target organ, like a blood vessel, and when it's stimulated, it causes constriction. Simple. But alpha 2 is very interesting. It's often located on the nerve that released the noradrenaline in the first place. It acts like a feedback brake. When it senses a lot of noradrenaline in the synapse, it sends a signal back to the nerve saying, okay, that's enough. Stop releasing more. It's a beautiful self-regulating system.
Okay, so now we have the complete map. We understand the messenger, its release, its cleanup, and the different kinds of receptors waiting for it. So now comes the really fun part. Let's talk about how we can use drugs to intelligently hack this system.
Very simply, these drugs, which we call sympathomimetics, work in one of three ways. First, you have the directly acting drugs. These are like a master key. They go straight to the alpha or beta receptor and activate it themselves. Second, you have the indirectly acting drugs. These drugs don't have the key, but they are like a troublemaker that goes and kicks the neuron's door, forcing it to release its own supply of noradrenaline. And third, you have the mixed action drugs. These are the clever ones. They do both. They can directly activate the receptor, and they can cause more noradrenaline to be released. And let's go back to our master diagram, because now it should make perfect sense. Look at all those drug names. Each one is a tool that targets a specific step we've just learned about. You see cocaine? It blocks the net reuptake pump, that vacuum cleaner. You see reserpine? It blocks the VMAT pump that puts noradrenaline into the storage vesicles. Tyramine? It sneaks in and kicks noradrenaline out. You see? Once you understand the basic physiology, the pharmacology becomes logical. It all connects.
All right, for our final section, let's tackle a topic that is absolutely 100% a high-yield topic for your exams, especially for the viva voce. We are going to compare the three-parent catecholamines: adrenaline, noradrenaline, and isoprenaline.
Please pay close attention here. The key to understanding this entire table is receptor selectivity. Look at noradrenaline. It acts on alpha 1, alpha 2, and beta 1. What's missing? Beta 2. It has practically no beta 2 action. Now look at isoprenaline. It's a pure beta agonist. It hits beta 1 and beta 2. What's missing? The alphas. It has zero alpha activity. And finally, adrenaline. It's the jack of all trades. It hits all of them. So now think about the consequences. Noradrenaline cannot relax the bronchi because that's a beta 2 job. Isoprenaline causes a fall in blood pressure because it powerfully dilates blood vessels through beta 2 without any alpha 1 constriction to oppose it. It's all logical if you just remember the receptors.
So, I will leave you with a clinical question to think about. Based on everything we just discussed, why would giving noradrenaline to a patient suffering a severe asthma attack be completely and utterly useless? Think about the receptors. Once you start making these connections, pharmacology stops being about memorizing endless lists and starts becoming simple common sense. Keep asking why yaar, and I promise you it will all click into place. Chalo, we'll see you in the next one.
All right, everyone, settle down now, settle down. So today, we're tackling a topic that you are going to see, well, every single day in your clinical practice: adrenalgic drugs. Now, these are the medicines that let us, hijack our body's own primal fight-or-flight system. Trust me, understanding them is absolutely crucial. So let's just get right into it.
Okay, let's start with a code blue situation, right from the get-go. Imagine this: your patient is crashing. BP is nowhere to be found, they can't breathe. It's anaphylactic shock. In that moment, your quick thinking and your knowledge of one single drug is all that stands between them and death. So keep that question in the back of your mind as we go through the basics. You see, before we can even think about using these drugs, we first have to understand the system they're playing with. The adrenergic system is basically our body's own rapid response team. It's that sudden jolt of energy, that super awareness you feel in a dangerous situation. That's the fight-or-flight response, and it's all managed by some very specific chemical messengers.
And the main player in this whole story is this molecule right here, noradrenaline. We'll just call it NA. When your brain senses a threat, NA is the chemical that just floods your nervous system, telling your body, hey, get ready for action. It's really the spark that ignites the whole response.
Now, NA can't do its job all on its own. It needs to connect with something on the surface of our cells. You can think of them like locks on a door. We call them adrenergic receptors, and they come in two main families, alpha and beta. So when NA, which is the key, fits into these alpha or beta locks, it unlocks all the effects we associate with fight or flight. Simple as that.
Now look here, butchos. This diagram, this is super important. This is the adrenergic synapse. This is where all the action happens. You see these little bubbles, the vesicles? That's where noradrenaline is kept stored away. And when the nerve fires, boom, NA is released, it crosses this tiny gap, hits the receptors on the other side, and then it's very quickly sucked back in for later. It's a really neat, really efficient system. Pay attention to how it works normally.
Okay, so that's how the body does it naturally. Now, let's talk about how we, as doctors, can step in and take control of this system in those absolutely critical moments. These are the heavy hitters, the drugs you'll be reaching for when a life is literally hanging by a thread.
So let's go back to our first question. That patient in anaphylactic shock. What's happening? Their blood vessels have dilated completely, so their blood pressure has just vanished, and their airways are swelling shut. The body's own system has gone completely haywire. We need a single drug that can fix all of these problems at once. And the answer, and I want you to burn this into your memory, is adrenaline. It is the only thing that will save this patient's life. Now why? Because it's a powerhouse. It hits both alpha and beta receptors, so it clamps down on the blood vessels to bring the BP back up, it forces the airways open to stop the bronchospasm, and it reduces that life-threatening swelling in the throat. It is the perfect antidote, a complete package deal.
Okay, let's take another emergency. Cardiogenic shock. This time, the problem isn't the blood vessels, it's the heart itself. The pump is failing. Maybe after a massive heart attack, the muscle is just too weak to push blood around the body.
For this kind of problem, we need a much more focused tool, and that's where we bring in dobutamine. It's a selective beta-1 agonist. And where are most of the beta-1 receptors? That's right, in the heart. So its main job is to increase the force of contraction. It basically makes the heart squeeze harder. And the really clever part is, it does this without jacking up the heart rate too much, which is the last thing a failing heart needs.
All right, let's switch gears. We're moving out of the ICU and into the OPD. Because adrenergic drugs aren't just for life-or-death situations. We use them for all sorts of common, everyday things, from a simple blocked nose to needing an eye exam. Let's see how.
You know that awful, stuffy feeling you get with a cold? Well, that's caused by dilated blood vessels in your nasal passages. So what's the fix? We use alpha agonists in nasal drops. They cause vasoconstriction. They shrink those vessels, and voila, you can breathe again. Drugs like xylometazoline are really popular because they work for a long time, up to 12 hours.
And I need you to listen to me very carefully on this one. This is a serious warning for all of you future doctors. You have to tell your patients, do not overuse these drops. If you use them for too long, they can actually damage the tiny hairs, the cilia, in the nose. This can lead to a nasty condition called atrophic rhinitis, a classic case of the treatment becoming worse than the disease.
And the list of uses just keeps going. We use phenylephrine eye drops to dilate pupils so we can get a good look at the fundus. For asthma patients, we use selective beta-2 agonists like salbutamol to open up their airways. We even add a tiny bit of adrenaline to local anesthetics. Why? It constricts the blood vessels right there at the site, so the anesthetic stays put for longer and there's less bleeding. Pretty clever, isn't it?
So far, we've mostly been talking about the body, the periphery, but some of these drugs are special. They can cross the blood-brain barrier and start messing with the adrenergic system inside the brain, and this opens up a whole world of both therapeutic benefits and, unfortunately, very dangerous abuse.
Let's go back to our synapse diagram. Remember that nice, orderly system? Norepinephrine gets released, does its job, gets taken back up. Well, a drug like amphetamine comes in and just throws the entire rulebook out the window. It doesn't just stimulate the system, it literally stages a hostile takeover.
So here's how this takeover works, in 3 steps. First, amphetamine sneaks into the neuron using the same transporter meant for NA. Second, it barges into those storage vesicles and kicks all the noradrenaline out. And third, it hijacks the transporter itself and reverses it, forcing it to pump all that displaced noradrenaline out into the synapse. The result? A massive, uncontrolled flood of NA.
And this slide shows us the perfect example of a double-edged sword. You see, in a controlled, small dose for a condition like ADHD, this flood of NA can actually help focus the brain and improve attention. But in the high doses seen in abuse, that same flood causes psychosis, panic attacks, aggression, a complete and total mental breakdown. It's the same drug, but two completely different worlds.
Now, because these drugs are just so incredibly powerful, the potential for harm is, well, it's huge. As the doctors who will be prescribing these, you must be extremely aware of the side effects, the risk of tolerance, and the very real dangers that come with some of these medicines.
You absolutely have to know this term, tachyphylaxis. It means a very rapid development of tolerance. So you give a dose, and it works. You give the same dose a little while later, and nothing. Zip. Ephedrine is the classic example. It works by pushing stored NA out of the nerve, but that supply of NA is limited. It's like a small fuel tank. Once it's empty, the drug has nothing left to release, and it just stops working until the neuron has time to make more.
In this slide, this is a very important cautionary tale. For a while, some of these sympathomimetic drugs were used widely as anorexics for weight loss. The results were a complete disaster. Drugs like fenfluramine were found to cause permanent damage to heart valves. Another one, sibutramine, was linked to heart attacks, strokes, and even death.
Because of these incredibly severe dangers, these drugs have been taken off the market. They are banned here in India and in most countries around the world. It's a very powerful reminder for all of us. A drug's effectiveness means nothing if it isn't safe.
Now, Butcho, everything we've talked about today has been about stimulating this system, right? We've been talking about the agonists, the drugs that act like the accelerator pedal. But look at this slide. This hints at a whole other universe of drugs designed to do the exact opposite. These are the adrenergic blockers, the antagonists. In other words, these are the brakes. So, this brings me to a final question to leave you with. We've seen how absolutely life-saving it is to activate this system, to press that accelerator. But why on earth would we ever want to block it? In what clinical situations would you, as a doctor, want to deliberately put on the brakes and stop the effects of noradrenaline? Have a good think about that. We will cover that whole other world of adrenergic blockers in our next session. Thank you.